The DaunoDouble trial that you mentioned and that we evaluated and analyzed the results and which we'll be able to present here at this meeting was a classical treatment optimization trial, which means we used conventional drugs and changed the schedule or the dosage to see whether we could still get some beneficial effect, although the classic conventional chemotherapies for AML have been around for decades now. So the DaunoDouble trial asked the question whether 2 doses of Daunorubicin would make a difference in terms of response rate of patients that are young and fit for intensive induction. The historical standard to use in induction is 45 milligram per meter square Daunorubicin, and there have been 3 randomized trials showing that double the dose, which is 90 milligram per meter square, is beneficial both in terms of remission but also in terms of survival. Now, 45 milligrams has not been used very widely in Europe during the last decades. The standard in Europe and in other countries too has been 60 milligrams rather. So there's a big question whether 60 milligram is equally effective to 90 and you can maybe avoid 30 milligrams of Daunorubicin extra, or whether a 90 milligram is still more efficacious. Therefore we did a randomization, and so one half of the patient received 90, the other one received 60, and we looked 15 days after the start of treatment how many blasts were still left in the bone marrow. That is what we called early response assessment, and we defined a good response by blast count below 5%, and we compared the percentage of patients having below 5% blasts in the 90 milligram versus the 60 milligram arm. And the results will be presented here, and they show that there is no real clinically significant or statistically significant difference between the 2 dosages, which is in line with other results such as from the English group, the NCRI trial, also comparing 90 with 60 milligram, and they also could not show differences in response or remission rates.